Welcome, everyone, and thank you for attending our Ask the Experts series event. Gastrointestinal cancer genetics experts discuss risk, screening, and treatment. My name is Juanita Rogers, Vice President of Health Education and Communication at Force, and I will be your host for this event. FORCE stands for Facing Our Risk of Cancer Empowered. We are a national nonprofit organization devoted to improving lives of individuals and families who are facing hereditary cancer. And our community includes people with an inherited mutation in BRCA, the Lynch syndrome genes, and additional genes that include ATM, CHEK2, PALB2, or any other gene linked to cancer. We accomplish our mission through our support, public policy, education, and research programs, and through forging strong partnerships with other organizations. You can find out more about our programs by visiting our website at facingourrisk.org. We want to take a moment to thank our program sponsors for their generous support. Our presenting sponsor is AstraZeneca. Our empowerment sponsors are Lilly and Merck. Our affinity sponsors are Eisai, GSK, and Novartis. And our community sponsors, Foundation Medicine, Pfizer, and Exact Sciences. And here are experts for the interview portion of the program. Dr. Michael Hall is the gastrointestinal oncologist and chair, Department of Clinical Genetics, and professor at the Department of Clinical Genetics, as well as director of gastrointestinal risk assessment at Fox Chase Cancer Center. Dr. Bryson Katona is a physician scientist specializing in risk assessment and management of hereditary gastrointestinal cancer predisposition syndromes. At Penn Medicine's Abramson Center, he serves as the director of the gastrointestinal cancer genetics program, as well as being the director of the Lynch syndrome program. Both panelists are also members of Force's Scientific Advisory Board, and we thank them both for being here. Just as a reminder to our attendees, we will not be providing medical advice, so please consult with your doctor about your medical options. And before we launch into really specific questions, I wanted to start with you, Dr. Hall, and ask for you to kind of share a little bit more about the types of cancers that fall under GI or gastrointestinal cancers, and which ones are most likely to be hereditary.
Sure, I'm happy to. I just want to thank everyone for coming to this great session tonight, and really also thank the Force group for inviting me to help guide through this. I'm really excited. So the GI system, it's actually one of the most diverse in the whole body related to cancers and different cancer types. There's lots and lots of different organs. This is because these tissues, the reason we see cancers in the GI tract is that the tissues of the GI tract get exposed to many substances from the outside. Food, good and bad, impacts the whole GI tract. Alcohol, cigarette smoke, with saliva in the cigarette smoke, environmental factors. So all these things are related to whether people get cancers in the GI tract. And so just starting from the top to the bottom, or maybe I'll start from the bottom to the top. We know that anal cancers, rectal cancers, colon, appendix, of those cancers of the lower GI tract, it's really rectum and colon, which are more related to hereditary risk. Anus and appendix cancers less so. Also small bowel cancer, some of those are also certainly ones that can be related to genetic risk. In the upper GI tract, we see and some of these are on the diagram that's here, the duodenum, which is the first part of the small bowel, a small organ of the duodenum called the ampulla, which is where juices come out of the pancreas and pour into the small bowel, also from the gallbladder. So gallbladders, pancreas, and then we now these days think of bile duct cancers as being both intrahepatic or extrahepatic. So those are all kind of middle GI tract cancers as well as the liver. Of those, small bowel cancers, again, some of these ampullary cancers, pancreatic cancer, which we'll talk more about later, gallbladder cancers, really almost any of these can have a hereditary component. I guess the big standout that I would say is non-hereditary. Generally, cancers of the liver are not hereditary, although you do sometimes find hereditary risk genes in those patients. Then stomach cancers, esophageal cancers. Are the last ones that are related to hereditary risk in our GI cancer. Stomach are much more so often hereditary, esophageal somewhat less so. There's also a group at the junction between the esophagus and the stomach. Again, a portion of those are sometimes hereditary.
Thank you. And you did mention this is a complex area, so we will be focusing on stomach, colorectal, and pancreas. But let's talk about cancer genetics and risk. So, Dr. Hall, which genes are linked to colorectal cancer risk?
Yeah, so there's a whole bunch, and I think it'd be a lot to go into all of them, but I want to just hit the high points here. The high risk genes for adult hereditary colorectal cancer risk are certainly the APC gene, which we know underlies a syndrome called familial adenomatous polyposis, not very common in the population, but can cause lots of polyps and increases cancer risk. Probably the most common and the most important that I think we'll spend the most time discussing at some point are the Lynch syndrome genes. Lynch syndrome is very common, and those genes are called the mismatch repair genes. About 1 in every 300 folks in the population is affected by Lynch syndrome. Other genes that are important, though, include genes associated with rarer syndromes called JPS, the juvenile polyposis syndrome, related to the SMAD4 gene and the BMP-R1A gene. There's rare genes called POL-E and D1, and NTHL1, RPS20. Again, these are rare. There's also a bunch of other genes that are just less that we less commonly see, but I think I'll emphasize that when we test people for hereditary risks these days, we actually test kind of as broad of a spectrum of genes as we possibly can, even genes that are super, super rare in the population. And so I want folks to know that the generally testing these days with panel testing is very comprehensive. So we cover many of these other genes that are listed on this slide towards the bottom, GREM1, MBD4, TP53. Again, these can cause colon cancer, but generally lower risks and much less common causes.
And Dr. Katona, anything to add to what Dr. Hall has said?
Thanks, Juanita. Yeah, I'd also like to, similar to Mike, just take the opportunity to thank you for the invitation to come. Thank Force for putting this on, and of course everybody in attendance. Thank you all for hopping on for this great session. I'm clearly very excited about it. So excited that I dressed up to match the background of the Zoom. Unintentional. Our scrubs are just blue in color. But to get to your question, Juanita, most of these colon cancer risk genes are actually associated with what's considered or called a dominant pattern of inheritance, meaning that if there's someone who's affected, that their children will have a 50% chance of inheriting that gene mutation. And with a dominant pattern of inheritance, the mutations don't skip generations. So, if one of your kids has it, then the kids of that kid may also have it. But if one of your kids tests negative for the mutation that you have, then their kids will subsequently not have it either. And it's important to note that this 50% chance of having it is for each individual child. So sometimes we see families where all children have inherited the mutation. Sometimes we've seen families where none of the children have inherited it. And then more often than not, we see a mixture of some children inheriting the mutation and some children not. In addition to dominant genes, there are also syndromes that are called recessive meaning that you only get the cancer risk if you inherit one of the genes from each of your parents, so that you carry two bad copies of the genes. These are oftentimes very difficult syndromes to parse out from a family, because oftentimes if you look up in the generations, there's no family history that would be consistent with the particular syndrome, because really the affected individual needs to have one gene from both parents.
And I'm sure there will be questions asking a little bit more later on in the breakouts, but I did want to see for people who are at high risk for colorectal cancer, besides the increased screening, is there anything that might be related to diet, medications that they can take to lower their risk? Anything at all? And Dr. Hall, we'll start with you.
Sure, yeah. A lot of research has certainly gone into this area, and I'll try to cover the high points, but also then give Bryson some time to speak too. But certainly, I think the strongest research has supported, first of all, from a dietary standpoint, diets that are heavy in red meat tend to have about a 20% increased risk of colon cancer, whereas diets that are richer in fruits and vegetables generally have lower risks of cancer of a similar magnitude. Fiber, we know, although studies have somewhat been mixed in the past, has been associated with lower risk, about 20 to 30%. Alcohol, we do think has some increased risk of cancer, although not as high as some of the other factors. A couple that are talked about a lot these days, obesity. We know, there's an obesity epidemic in the country, and that's about a 20 to 30% increased risk, so higher risk of colon cancer in folks who are obese. But yet, data have shown that folks who get more physical activity seem to have lower risk of colon cancer. Again, similar range, about 25%. We will talk a little bit later about a study that specifically looked at that area that I think is super interesting to discuss. One last one, aspirin, as we say in medicine, a chemopreventive agent. Aspirin seems to have risk modulating activity as well, either in folks who have survived a colon cancer or in folks who are trying to avoid ever getting a colon cancer. So I won't get into all the specifics of that, but I'm happy to answer questions later on about that. But certainly aspirin and calcium to some degree as well has been associated with a lower risk of colon cancer.
And Dr. Katona, anything to add about the risk factors?
I think Mike gave a fantastic summary, but one other thing to think about, while not a dietary choice or medication, but smoking is another major risk factor for colorectal cancer. So smoking cessation can certainly reduce risk. And one other comment just to say about all of these risk factors is that, especially when you're thinking about them in the context of a hereditary cancer predisposition, these are small changes in risk, but when you look at them in magnitude to what the risk that is created by some of these genes, the risk that these individual factors play in that long-term cancer risk may be smaller than one would expect.
Incredibly helpful. And Dr. Hall, you did mention the genes that are associated with Lynch syndrome. So can you tell us a little bit more about those and the risk for GI cancers? Is that the same for all of the genes? What can you tell us?
Sure, I'm happy to. And I'll let Dr. Katona add some to this as well. But I'll just start by reviewing the genes. There are really sort of 5 genes that are associated with Lynch syndrome. One that acts via its impact on one of the others. So I kind of think of the Lynch genes as being 2 sort of higher risk genes, one that's sort of in the middle and one that is a lower risk gene. So the 2 high risk genes are MLH1 and MSH2. Those tend to be the ones that are rarer in the population, but again, associated with the highest cancer risks, particularly colon cancer and endometrial cancer and MLH1 and MSH2. We actually tend to see more of the what we say extracolonic cancer, so less colon cancer. There's still a lot of colon cancer, but there's a lot of other cancers that can happen as well. MSH6, the colon cancers tend to be a little later onset and somewhat lower risk when we look at a population level of risk of cancer. And then PMS2, we actually just, Dr. Katona and I both sit on a guideline for the National Comprehensive Cancer Network, and we just issued new guidelines about PMS2, and the risks have been somewhat downgraded. We think the risk of colon cancer is about 20% over a lifetime, the risk of endometrial cancer about 25%. The last gene, EpCAM, as I mentioned before, actually sits a little bit upstream of the MSH2 gene, but we think when there are mutations there that it knocks out the function of MSH2, so it acts through MSH2. I'll stop at this point because I know this is Bryson's area of expertise, so I want to give him a chance to talk as well.
Yes, please, Dr. Katona, anything to add here?
Yeah, one thing I would just like to highlight the point that Mike made, that, with, for example, PMS2 carriers having lower colorectal cancer risk, it's important to think about Lynch syndrome and management of risk really based on the gene that runs in the family. And so we're doing a lot more individualized management for individuals, based on the gene, and not looking at Lynch syndrome as kind of the same diagnosis for everybody. And so I think that's really important, because for individuals with Lynch syndrome, if you speak to others or read things online, you may find people are getting managed in very different ways, and that's oftentimes because there are very different cancer risks depending on certain factors that are specific to you.
Is helpful, and there's a lot here, but we do have a QR code if people want to get more information, and of course they're going to look towards those breakout sessions with you both. But Dr. Hall,
Can I say one thing
oh, yes, please.
It's one thing we've been sensitive about in the guidelines is to try to still give a range of room for people to get screened more conservatively or less conservatively, because we don't want to, we know some people are more risk averse and some people, want to be in the doctor's office as least often as possible. And so we have tried to be as sensitive to that as possible, so that, even though we've refined our risks, we want to give people the ability to get screening as they wish.
Absolutely. Thank you, Dr. Hall. And can you tell us a little bit more about which genes have been associated with stomach cancer risk? We have a few up on the screen here, and of course, would want to hear from you.
Sure, 100%. There's a lot of overlap because a lot of these genes act on the whole GI tract. But again, the APC gene that we know was associated with that syndrome I mentioned before called FAP, there's a low, about a 2%, 3% lifetime risk of stomach cancer. The biggest gene that we sort of think of is one called CDH1. That's not actually one that we think has so much of a colon risk, but carriers, although uncommon in the population, do have a quite high risk of developing a specific kind of stomach cancer. They develop especially diffuse stomach cancers, often described as having signet rings. There's a newer gene on the block that actually Dr. Katona has done some great work in that I'll let him talk about, called CTNNA1. And then the Lynch genes that we mentioned before, and then a spattering of other genes, again, that we just don't see that often because they're not that common in the population, like SMAD1, STIC11, TP53, and some other genes that may very minimally increase risk of stomach cancer. But again, I'll stop for a minute and let Dr. Katona add, because he's done work in CTNNA1.
Yeah, so
Yes, Dr. Katona.
yeah, CTNNA1 is a kind of a newer, as Mike mentioned, a newer gene on the block. It is fairly similar to CDH1, as it increases this kind of rarer type of stomach cancer called diffuse gastric cancer. And we're still trying to figure out other cancer risks associated with this gene, and we currently have a nationwide study trying to recruit families, but we're not sure at this point if there are other cancers outside of stomach cancer that are associated with CTNNA1. And the last point I'll mention here is that there are some genes where overall they may not increase stomach cancer risk a ton. However, with co-infection with a bacteria called H. pylori, which I think we'll get into a little bit more detail about later, there can actually be quite an increased risk. And that includes primarily the genes that typically increase breast cancer risk, like ATM, BRCA1, and BRCA2.
And before we get into any more of the details, let's move on to discuss some of the risk factors for stomach cancer. Is there anything that our community needs to know? And Dr. Hall, will start with you and move to you, Dr. Katona.
Yeah, so the risk factors as listed here, I think are certainly the most important, and Dr. Katona just covered one of the most important ones. We know that H. pylori infection is certainly one of the strongest risk factors, and actually a large portion of the population, especially folks who were born outside of the U.S., we know is a higher risk of being a carrier of this very common bacteria that for many people is asymptomatic. But overweight, obesity, smoking, alcohol, and then specifically, we know that foods that are highly processed, pickled foods can be higher risks for stomach cancer. Whereas protective factors are some of the ones that we've sort of mentioned already. Diets richer in fruits and vegetables, coffee consumption may lower risk of stomach cancer, also physical activity. And then again, what we've seen over time is that stomach cancer rates overall in the population and in the world have gone down because we refrigerate our foods better and we don't have to use so much pickling and other things to preserve the food.
And Dr. Katona, before my next question for you, do you have anything to add to the risk factors here?
Only that I'd love to talk some more about H. pylori
Yeah,
whenever
gonna
that time
get to
comes.
it. So, Dr. Katona, Dr. Hall told us about the protective factors. So what are some of the other factors that might increase risk for stomach cancer that the community needs to know about?
I think Mike went through these protective factors, or these risk factors. So let's just go to H. pylori.
Oh, great.
So I think H. pylori, for those who aren't familiar, is actually a bacteria. It's a fascinating bacteria that colonizes the stomach. So it's really the only bacteria that preferentially prefers the acidic environment of the stomach. Now, what's interesting about this bacteria is that people typically will get colonized when they're very young, typically when they're toddlers. And this bacteria can persist in your stomach essentially throughout your lifetime. It's very common, as Mike mentioned. If you look worldwide, it can affect up to a third to a half of individuals across the world. In the United States, carriage rates are lower. I think probably around 1 in 5, 1 in 6 to 1 in 5 individuals may actively carry H. pylori, but it's still a lot of people. And most people that carry it don't know that they actually have this bacteria. Now, in the vast majority of people who have this H. pylori bacteria in their stomach, there's no downside or no harm that comes of it. But in some individuals, it can induce inflammation in the stomach, which can ultimately lead to increased risk for stomach cancer development down the road. Now, how do you test for H. pylori? That's a question that I get very frequently. There are multiple ways that you can test for it. One is if an upper endoscopy is being performed, where a camera is put from the mouth down into the stomach, either for screening or for evaluation of upper digestive symptoms. During one of those tests, small little biopsies can be performed of the stomach to look for this particular bacteria. But there are non-invasive ways as well. So there's something called a breath test, where you drink a little bit of a sugary substance, and then they check your breath to see if you're producing this certain metabolite that we see with H. pylori. Or you can also test it via a stool test. So essentially, you can collect a stool sample and submit that, and they can test for any evidence of this particular bacteria. And for individuals who do carry this bacteria, especially if there's a risk factor, or if they're having digestive symptoms, it can be treated. Treatment typically involves a fairly hefty course of antibiotics, typically 2 antibiotics, along with some other medications that can reduce stomach acid. But it certainly can be treated in individuals where it's found, and oftentimes this is recommended for individuals at increased risk for gastric cancer.
And we do have up on the screen an X-ray that we did, along with the QR code for people to read up more, but I'm sure there will be individuals who will be in the breakout room with you, Dr. Katona, to ask more questions. So let's talk a little bit about pancreatic cancer risk and the genes associated there. Again, Dr. Hall, will start with you and move to Dr. Katona.
Sure. So again, you'll see some overlap with the genes that we've already mentioned for gastric and for colon cancer, but then there's some newbies on this list as well, especially in that high risk list. A gene called CDK N2A is one that we know can be associated actually with melanoma, but also with pancreas cancer risk. There are a couple genes on here that are associated with hereditary pancreatitis, PRSS1 and SPINK1, and then a gene associated with a quite rare syndrome, maybe 1 in 40, 1 in 50,000 people has this called STIC11 or Putz-Jaeger syndrome. The ones in the middle, the increased risk ones, are actually the ones that are super common in the population. And again, we've seen some of these already. The ATM gene, which is very common in the population, maybe one in somewhere between 1 in every 50 or 1 in every 100 people roughly is a carrier. The BRCA1 and BRCA2 genes, which we always associate with breast and ovarian cancer, but also particularly BRCA2 associated with pancreas cancer risk. The Lynch genes, which we've already heard about, are associated with pancreas cancer risk. PALB2, which is again a gene in the same family as BRCA1, BRCA2, also associated here with pancreas cancer risk. And then the P53 gene, which is associated with a syndrome called Li-Fraumeni syndrome, but also Li-Fraumeni-like, and is probably somewhat more common in the population than we used to think. But all of these contribute are actually quite common if you put all the pancreas cancer genes in those first two groups together, tested every patient who came through the door with pancreas cancer, we'd find about one in every 10 to one, about 10% to 15% of people will potentially carry one of these genes. So hereditary risk of pancreas cancer is quite common. And then at the bottom, there are some genes associated with neuroendocrine tumors, much less common, but nonetheless important to know about.
Absolutely. Dr. Katona, taking a moment to see if you wanted to add anything.
Yeah, no, Mike gave a great a great overview of those genes. I think we'll talk about screening though in a little bit, and I think that's a common question that typically comes up.
Certainly. So there was a recent article published that was linking oral bacteria and yeast to pancreatic cancer risk. And Force is going to have an X-ray review on the article coming out very shortly. So we just wanted to put it for the audience to be aware of. Before we move on to the next question for you all, just wanted to make sure you didn't have anything to add or to note for the audience before we move on.
Do you want to go first, Bryson? Then I can add.
Yeah,
And
no,
if that's okay.
Yeah, it's a very interesting study. I think a lot of these very high profile studies, they get a lot of press and they're very interesting. I think nothing here is directly translatable to patient care yet.
Yep.
But certainly down the road, it could be an important starting point for developing new tests.
Yeah, and I think maybe I totally agree with that, and maybe sort of like the H. pylori story. I think what it tells us is there are these interactive factors perhaps that interact with our perhaps our genetics and other things that probably contribute to our risk of pancreas cancer overall, and whether more studies pan out about how oral bacteria and fungal microbiome may modulate that risk. I think we'll have to see, but I agree with Bryson that sometimes the initial study makes a big splash, but I think we'll have to see whether this actually impacts clinical care.
Yeah, it's helpful for the audience to hear. Absolutely. So we'll move on and we'll talk about GI cancer screening and prevention now. And Dr. Katona, we'll start with you. So when we talk about high-risk screening for colorectal cancer, what does that typically entail?
So great question. I think probably the most important thing is to define when you say what is someone at high risk of colorectal cancer. And so, we would typically define that as carrying one of the gene mutations that Mike had mentioned earlier. But it isn't always just genetic. So if an individual has a history of colon polyps or potentially even a single polyp that's a high risk polyp, that can put them into a high risk group as well. or if you just have a family history of colorectal cancer, especially if it's a first-degree relative. So first-degree relative is a relative that you're directly related to, so like a parent or a sibling. And usually when we talk about colorectal cancer screening for high-risk people, usually we're talking about colonoscopy. Now, in somebody who's average risk, who is not high risk, there's many different ways that we can screen for colorectal cancer, including doing CT scans or stool-based tests. However, for high-risk individuals, really colonoscopy is the preferred modality because it's the best for detecting not just cancers, but most importantly, polyps in the colon, which are what turns into cancer down the road. And colonoscopy, of course, can allow those polyps to be removed to prevent cancer development.
This is helpful. And just moving on to a little bit about pancreatic cancer screening. Dr. Katona, what does pancreatic cancer screening include? And can people just get a prescription from their primary care physician and go to any hospital for screening? What can you share with us?
Yeah, pancreatic cancer screening is, I think, probably one of the most talked about topics, in the screening world, and I think that's because it's a fairly new concept to a lot of people. But typically, pancreatic cancer screening for those that would qualify for screening would involve annual imaging of the pancreas with either a MRI of the pancreas that has some special sequences that allows us to get an extra close look at the pancreas and the ducts that run through the pancreas, or something called an EUS, which is an endoscopic ultrasound. And that's where a thin camera is put from the mouth down into the stomach. And the pancreas actually sits right behind the stomach. And so we can use that ultrasound probe on that camera to look through the back wall of the stomach to actually see the pancreas. Typically when patients are undergoing pancreatic cancer screening, it's preferred that these tests are done in higher volume centers or by higher volume providers, basically providers that are doing a lot of this type of screening. So, if you're getting an MRI of your pancreas, you want this MRI looked at by someone who's reading a lot of MRIs of the pancreas. Or if you're getting the endoscopic ultrasound, you want someone who's doing a lot of endoscopic ultrasounds to look at the pancreas, just because there's going to be an increased familiarity with these subtle high-risk lesions that they're looking for. Now, in terms of getting a prescription from their primary care doctor, I think pancreatic cancer screening is not as cut and dry as colorectal cancer screening, and oftentimes there are select groups that will qualify for pancreatic cancer screening, and even once qualifying, I think it's important to talk through the different options for pancreatic cancer screening and whether or not pancreatic cancer screening may be something for you.
Yes, and we do have another slide with some of that information. So sort of in reference to this and kind of making sense of it for our audience, Dr. Katona, what can you share here about that recommended screening?
So here there are a lot of the guidelines for the high-risk groups that should potentially consider pancreatic cancer screening. I think importantly, pancreatic cancer screening is clearly not recommended for average risk people. So, for individuals where there's no strong family history of pancreatic cancer and where there's no gene mutation in the family, those individuals really should not be undergoing pancreatic cancer screening. But as listed on the slide here, those recommended to undergo screening, are these individuals with these pancreatic cancer gene mutations. Now, these are the gene mutations, but I will say that, we do offer screening to individuals with strong family histories alone without an identifiable gene mutation. That's individuals that come from families with something called familial pancreatic cancer. And so that's where you have at least 2 members of the family that have had pancreatic cancer. And those 2 members need to be directly related to one another. So, for example, your mother and your brother, or your mother and your mom's father. In those situations, that would be familial pancreatic cancer, and then you may potentially qualify for pancreatic cancer screening. Now, it's also important to talk about when we're thinking about screening, it's important to talk about, if you do qualify based on one of these genes or a strong family history, what is the right age to start? So there are actually different recommendations based on the gene. So certain genes, you know, people may start a little bit earlier. But you know, in general, we would say pancreatic cancer is not a cancer that typically affects very young people. So for most people undergoing pancreatic cancer screening, usually the recommendation is to start around age 50. Now, some things may lead to earlier ages of pancreatic cancer screening commencement. And so the big factor there would be if there was a very early pancreatic cancer in the family, that may lead to a slightly earlier age of initiation.
This is helpful because people need to really understand why certain measures might be taken in their case. And I'm sure there will be additional questions. But I did want to ask a question because you mentioned that people should go to high volume centers with a pancreatic cancer screening program. But what if they can't access that screening? And I think I'll ask that of both of you, just to see. And Dr. Hall, we can start with you and move to you, Dr. Katona.
Sure. I think one of the biggest challenges in our country is that, care is not well distributed and high volume centers that where you have the expertise of GI docs who can do EUS and some of these other great screenings tend to be concentrated in cities and certain states over others. And so it does make it really challenging, particularly for rural Americans. So there's no perfect answer to that problem, and it's certainly not going to be solved probably anytime in the near future. I think that um, probably one of the ways that docs or providers in settings where an advanced endoscopist is not immediately available, they could potentially use things like MRI or variations of MRI like MRCP to offer some sort of screening. And then if there was something higher risk or concerning found, then kind of make that jump to kind of refer someone into a higher volume center that may be a little bit more of a distance to get to. I think without this certainly not being the standard of care right now, I think that on the not too distant horizon as well are hopefully going to be tests that are blood-based tests that will hopefully allow us to offer people some level of screening as well, maybe even via a blood test. Again, I don't think that technology is going to be ready next week or maybe even next year, but it's coming. I think we are getting better at detecting very small amounts of DNA in the blood from tumors that will hopefully someday allow us for people even in the most rural places to be able to get tested or screened for these kinds of cancers.
Dr. Katona, anything to add?
I think the comments about the blood tests are, incredibly important, and we're all very hopeful that in the years to come we will have a blood-based test that we feel comfortable kind of employing as the primary screening method. Now, as Mike mentioned, we're not there yet, but there's a lot of research in this space, and so it's a very exciting time. And hopefully, in the years to come, we will have that option available for patients.
Mhm. And Dr. Hall, in addition to potentially the blood test, are there any other options that might be emerging for the community to kind of be aware about, or any research that is happening for them to know?
For pancreas cancer screening, those were the main ones I think that I
Okay,
was thinking about. Yeah.
great. And so we're going to move on and we're going to talk about what happens after the screening. So, with more people having the screening done, we're hearing more about pancreatic cysts. And so, Dr. Katona, I wanted to ask you, can you describe what those are and what the concerns someone may have and may need to have addressed with a pancreatic cyst?
It's a great question. When I order pancreatic cancer screening for individuals, I always have a discussion with them and kind of level set, what to expect. Of course, we all would love to have a perfect pancreas. I mean, who wouldn't want to have a perfect pancreas? But in fact, these imaging modalities are actually very sensitive. So the chance of picking up some abnormality on the pancreas is incredibly high. Most of these abnormalities have no risk and no long-term impact. But it's important to tell people that 3 to 4 in 10 people will have some sort of, abnormality that comes back on the report of their pancreas. Now, cysts are what we see most commonly, and cysts are basically these little fluid-filled structures that pop up in the pancreas. Typically, as you get older, the risk of having a cyst increases. So, if you did an MRI on 120-year-olds, you may find one cyst, but if you did an MRI on 160-year-olds, probably 30 to 40% of them would have small cysts. And although cysts are common, most of these cysts are totally benign and are not going to develop into any issue down the road. However, once we do find a cyst in the pancreas, it's something that we continue to monitor. And the biggest things that we're monitoring or probably the most important thing is the size of the cyst. And so if we're following the cyst year over year over year, and we're seeing that cyst continues to grow and grow and grow, then that may be a cyst that is of concern. However, if we find a cyst and then for each year for the next couple years, it doesn't change in size, we're far less concerned about that particular cyst. And it's not just the growth rate, but also the overall size. And 1 centimeter is kind of our threshold for a cyst that we would put into kind of a category of being a higher risk cyst compared to others. But typically, if somebody goes through pancreatic cancer screening and a cyst is found, then usually we're kind of stuck monitoring that cyst moving forward. But most of them will never amount to anything of concern.
That's helpful. So we're going to move on to our next section because we know that there is evidence that suggests that aspirin lowers the risk of certain GI cancer. So we wanted to talk a little bit more about that. And Dr. Hall, we're going to start with you. Is there any information you can provide about which types of cancers aspirin can prevent and who should consider taking aspirin? Any information you can share?
Sure. So the data are by far the strongest in colorectal cancer, and that's actually where we also have some, interventional data, prospective data preventing polyps with aspirin. So that risk benefit may be as high as a 20 to 30% risk reduction. Most of the other data we have are observational data for like large population data that have looked at cancers and then which people in the population took aspirin or reported taking aspirin or not, and then looking at association. So the level of data are less strong, but I have to say have generally been quite consistent that generally folks who use more aspirin without getting into the weeds of what dose they took or whether they took it absolutely every day, generally folks who were aspirin users, and often those data have crossover with other NSAIDs like ibuprofen or other things that sound the same, but generally have lower risk of cancer. Now, and that includes like esophageal gastric cancer, pancreatic cancers have shown similar data, as well as liver, hepatocellular cancers. I guess one thing I want to emphasize, and I want to give Bryson a chance to speak too, because has expertise in this area too, is that I do think though that aspirin is a medication, and I think people should use it thoughtfully and carefully. And if they do want to take it as a way of potentially lowering cancer risk, they should definitely talk to their primary doctor first, right? You don't want people taking too much and then ending up causing stomach irritation or GI bleeding or other things. But there are safe levels to use that have been shown to be safe in the medical literature. And I think, certainly, like I said, the data have been pretty consistent that there's benefit, particularly in the colorectal cancer prevention space.
And Dr. Katona, anything to add?
Yeah, I think I just want to emphasize the point Mike made that, we don't want people going and just kind of taking aspirin, without thinking about other implications. There may be other, risk factors or things to, in your health history that may be a contraindication to it. So, it's worth, if you're interested, you can always have a discussion with your physician and your physician care team about it. I will also mention that, one group where we think that the benefit is even the greatest from aspirin, especially with regard to colorectal cancer, is in the setting of Lynch syndrome. where, you know, even a low dose aspirin a day may potentially reduce colon cancer risk up to, you know, 50%, which for somebody who has, you know, a 40 or 50% lifetime risk of developing colorectal cancer can be a major, major reduction. So I do encourage any individuals on who have Lynch syndrome to, you know, discuss aspirin with their care team to see if it may be right for you.
Is helpful. And in keeping with what we're hearing from the community, we know that there are studies that also suggest that eating high amounts of resistant starch may lower the risk of certain GI cancers. So, Dr. Hall, again, is there any information you want to provide to the community about what they may be hearing on this topic?
No, I think, you know, these data particularly come from a series of studies, CAP2, and then the CAP2 study was the major study that looked at starch. Particularly, data have been strong in the Lynch syndrome space. Actually, the same study that Bryson was just mentioning, where we saw aspirin data. Again, this is resistant starch resists digestion in the small bowel and ferments in the large bowel, and we think this overall, without getting into too much mechanism, has an anti-inflammatory effect. You know, I'll say that there was a paper out from the CAP2 group showing some benefit. The results have, I think, still, I think we still probably need a little more data, I think, to strengthen the perhaps the amount people should be taking and how long they should take it. And so I have not sort of fully recommended it to my patients yet, but I think the data were compelling.
Dr. Katona, did you want to add anything?
Yeah, the only thing I'll add is that, you know, I think in resistant starch, of course, is a subtype of dietary fiber. And so, you know, I always tell patients, you know, a high fiber diet's probably good for most people. And, you know, for individuals with Lynch syndrome, a high fiber diet, especially if it's enriched in these resistant starches, maybe even have more benefit.
And if people want to read more, we do have up on the screen the QR code to our X-ray that covered an article on this um, incredibly well. So please scan your phone using that. But I did also want to just, for awareness for our attendees, we're going to roll through the next few screenings and study information fairly quickly. But if our experts want to pause and add anything, please do. So what you'll see here on the screen, FORCE is promoting GI cancer screening and prevention studies on our websites. And so with this one, we're going to start with the colorectal cancer screening and prevention studies. You're going to see the QR codes here, and to the left of the QR code is the actual study. So you might have heard of them, but just have your phone ready, scan the ones that you think might be of interest for you, and just note that we will have the slides available after the presentation. And again, if our experts want to add anything about these studies, but I think there were some additional ones that you all really wanted to talk about. So we wanted to make sure that we got to those for you.
I just want to plug, I think this is an awesome resource. It's so hard, you know, to get online as a patient and try to like find these things. So it's just a great resource for the FORCE team to put these together so people can have an easier way of finding them. And it also gives that stamp of like, this is good research, right? So
Yes.
I think that's a great resource.
Wonderful. So we're getting to our next section here about GI cancer treatment and colorectal cancer treatment. So Dr. Hall, have there been any really exciting advances for people that have been diagnosed?
There have been so many, and I know we're going to have breakouts, so I don't want to, you know,
Yes.
take too long, but I'll just say, just in brief, the atomic trial has finally brought immunotherapy for MSI high or Lynch syndrome tumors and other MSI high tumors into the adjuvant setting after a curative surgery. I think that's very exciting. Again, I can answer more questions about this. This is a new space for immunotherapy in Lynch syndrome, so this is great. This study particularly looked at where aspirin, may be more effective in the treatment of colon cancers if a particular mutation in the tumor is present. Again, I'm happy to answer more questions about this, but this was a big study that was discussed this past year at our big GI oncology treatment conference, and just great work by this team. I especially love when something very common like aspirin can really impact how we've been treating a disease. It's not a fancy, super expensive drug. It's something very common.
I think we have a couple more.
Yeah, sure. So these studies, there have been a series of great studies that have looked at using immunotherapy in patients, early stage patients, potentially before they go to cancer, sort of as a proof of concept that there may be a group of people out there who can avoid surgery altogether. And these were some data from one of those studies where a single dose of immunotherapy was given to someone before they went to surgery, and we saw a very, very high response rate. Some of those people having complete eradication of disease with one dose of immunotherapy. I mean, who would have ever thought that 10 years ago?
I think our last one related to movement and exercise. Yep.
Yeah, and so I think this was when we were gonna focus, I think, a little bit more on was the this idea. I forget if we're gonna actually focus on the challenge study a little bit more in a later slide, but this was again a very important study that was discussed at our large national meeting this year, looking at colorectal cancer survivors, randomizing them to either a booklet about exercise or an exercise intervention that was getting a trainer who helped them develop an exercise program for 3 years. But I want to emphasize that this wasn't like running a marathon once a week. It was really for most folks, it was a home-based walking program, but it was structured and people were kept on task by having a trainer. And what they showed was, again, substantial improvements in what we call disease-free survival, the amount of time for folks who were going to recur before they would recur, overall fewer cancers, and not just colorectal cancers, but other cancers occurred in these patients over the follow-up time. So really amazing data, and really is making us all in oncology rethink, beyond all of our drugs, the other things we need to be telling our patients to do, and not just window dressing, but saying this is something that's actually going to change your survival.
Absolutely. And as a health educator and public health professional, I really enjoyed reading up on this study, and we do have an X-ray coming out about it. So thank you for sharing a little bit more for the audience so that they know to be ready when we have that published. So we're going to move on to the next section and talk about new advances for treating gastric cancers. And Dr. Hall, we're going to start again with you.
Yeah, I'll just make a couple points. There was a study. There's a new marker that we're using to treat gastric cancer that's called Claudin 18.2, and it's a target for a drug called zolbetuximab. So this has introduced a new option in frontline cancer treatment. One nice thing about this marker is actually a lot of people have it. So I think for some folks, this is really going to change the face of their options. The other thing I think that is on the list that I was going to talk about was HIPEC. And just for those on the audience, there's a little spelling mistake. It's HIPEC, but HIPEC is, I missed that, sorry, when I edited. But HIPEC is sending a surgeon in when there is a metastatic cancer within the belly to remove that cancer as best they can, and then to put chemotherapy in the abdomen. This is something that's been done for a while now in appendix cancers, is increasingly done in colorectal cancer, and is sort of moving into the gastric space. Again, I want to make the point that this is not something that everyone should be having at every center all the time, but I think what we're learning is there is a select group for whom this could be beneficial, and I think this is a discussion that patients should be aware of, that they could have with their providers.
Absolutely. And I think we have a couple for pancreatic cancers that we wanted to talk about, with the first one being for the CRAS vaccine.
Yeah, so there's been a lot of hype again. There's,
Yeah.
someone used to said at a conference recently that we used to think the KRAS mutant molecule was just untargetable, and now in the last 3 to 5 years, we've seen lots of therapies come out that target KRAS. And so one of the sort of most exciting is these various vaccines that have been developed to hit this mutation, where it looks like it may be the most effective is perhaps in the post-operative setting. Again, I want to emphasize, though, this is all still in the research setting. We still need larger phase 3 trials to confirm this, but I do think it is super exciting, and I think it probably will not be too many years and before we either have sort of a common vaccine that works for everyone, or whether we actually manufacture an individual vaccine for each patient. We certainly have the technology to do either one. I think we just don't know the answer yet of what's going to be the most effective, but these are some really exciting trials for patients with a cancer which we know has such a high risk of recurrence. It'll just be great if we have another treatment out there that can help delay that recurrence.
Absolutely. And I think there was another definition you wanted to provide for the
Yeah,
audience.
I just wanted to plug this as well because actually my colleague Dr. Katona and his group at Penn have been really leaders in this area of CAR T, which is sort of developing receptors that can be kind of introduced into the patient's T cells that may be able to specifically hit epitopes. And there is an investigator, a group of investigators at Penn who are particularly looking at this kind of technology for pancreas cancer. They have a trial ongoing that is looking at that. Again, still very early on in the game. This is certainly not standard of care, but I think this exciting way of modulating the immune system to potentially attack pancreas cancers in sort of a more kind of personalized way, I think is probably part of the recipe for the future.
Might
And
be our
then
last one. Yep. Oh, go ahead.
Yeah, and then in this last study, there's been a large trial going on for several years, sponsored by the ASCO, our major oncology society in the U.S., called the TAPER trial. And there have been some very exciting results where we have patients with mutations in certain genes that may be more responsive to immunotherapies. And this, I just pointed out here, one of these studies looking at patients who have pancreas cancer with BRCA1/2 mutations, either inherited or in the tumor. And so using immunotherapy, I just presented some data recently at a big conference in Europe, looking at combination immunotherapy and a drug that's already on the market, olaparib, or one of the same class of drugs. So I think we're learning that sometimes combination therapy for mutation carriers may be even more effective than some of the common chemotherapies we've used in the past.
This is really helpful. And again, want to remind the attendees that we are going to share the slides because we do have some trials here similarly with the QR codes and the list of the trial on the left-hand side. We will run through them a little quickly, so you'll want to just take a note or just keep your eye out for the slides when they're posted. We're going to go through and talk about treatment clinical trials for pancreatic cancer. Again, the QR code is here for you to scan, as well as clinical trials for advanced cancers, which will include GI. So this is helpful information that is on the FORCE website. We have just pulled it out for you to be able to find a little bit easier with the QR codes. Did want to make sure that we got to our closing thoughts from our experts. This has been an incredible panel, very informative. There's a lot happening, but I did want to take a moment, and we can start with you, Dr. Katona, and see what closing remarks you had for our audience, for our community.
Well, yeah, I would just first I'd like to thank Mike for that overview. I'm a simple gastroenterologist, so I always like to get hear about these incredibly exciting oncology trials. But I'm of course I live on the prevention side, and I think in the ideal world we wouldn't need any of these oncology clinical trials because we do a better job of preventing all of these cancers from developing. And so, yeah, I do just appreciate everybody attending, and I look forward to talking about some, prevention and screening strategies in the upcoming breakout session.
And Dr. Hall.
Well, thanks, Bryson, for that. Bryson's very modest. He's a very, very, a leader in the genetics and prevention world. But I want to echo what he said. I would love to see, in my lifetime, oncology go out of business because we prevented all the cancers that would have come to us before. Probably that's not going to happen because I'm getting older. But I think still, I like to focus, even though I treat a lot of oncology patients, my passion is also in the genetics and the prevention world because I really want to, get the word out. I think prevention is probably one of the most underused parts of medicine. So much work has gone into great research that we just need to get that word out. And I think, Force as a group serves as such, again, an awesome resource for folks. So I hope, everyone, we almost got up to like 100 people. Hopefully everyone heard that message that they should come to you, and then you guys can direct them towards the right places to get the things they need.
And an important message that may carry over into the sessions that we're going to get into in just a second. We understand at Force that there's a huge difference in awareness between BRCA 1 and 2 versus Lynch syndrome. Is there anything that you want to rapid fire share as far as raising awareness when it comes to Lynch syndrome being prevalent as much as BRCA 1 and 2?
I think most people are surprised at how common Lynch syndrome is, and often surprised that they've never heard of it, because just about everybody's heard of BRCA1 and BRCA2. But I think, spreading the word and increasing awareness and talking about it more, it's by far the most common thing that we're diagnosing now in our genetics clinic, and I imagine things are the same with Mike's program. But I think that I think that education will grow over time as we test more people and get the word spread effectively.
And Dr. Hall.
Yeah, I'll just anecdotally say I always try to put things in perspective for my patients. So about 1 in every 300 Americans is a lawyer. And so about 1 in every 300 Americans has Lynch syndrome. So if you think about how many lawyers you know in your life, that's probably the number of people you know who have Lynch syndrome. Most of those people are not aware because just testing has very much lagged behind BRCA. But I think with Bryson's and my effort, and we have a bunch of colleagues, and we all are in some collaborative meetings together. I think we're trying to to bring Lynch syndrome also up to speed, because I think it is ripe to be preventable if we can just get people to be more aware.
Very helpful, and we want to make sure people have time in the breakouts. So on behalf of Force, I want to thank our incredible experts for sharing their insights. Please stick around. We will open up the breakout rooms in just a moment. Want to remind you that we do have a short feedback survey. You can use this QR code to get to it. We are going to